Hello, everyone. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist. I am here in the bright and sunny South Florida area. I am the medical director for Broward Health North, and I'm also the antibiotic stewardship chair for the four Broward facilities, Broward Health North, Broward Health Medical Center, Imperial Point, and Coral Spring. And I also do infection control for Imperial Point. I'm a faculty for internal medicine, and I'm a PD for Infectious Disease Fellowship here. Today, I'm welcoming all the brand new residents and fellows. They just started yesterday, their journey, the next journey in their life. We are going to do a very interesting journal club. It's a kind of a journal club area. It is a very nice article. I want to highlight and let you all know that how infectious disease interplays with almost all specialties. So it works in collaboration. So this article is a great example of how cardiology and interfaces with infectious disease. Um, I trained at Duke University. I've been practicing here for 22 years. Duke is a internationally recognized center, and that's from where the endocarditis guidelines emerged, and they do multiple studies to enhance and how to manage complex infections, and a lot of guidelines, and they have contributed a lot. So cardiac device infections, they are very challenging, but as well as they are very rewarding. We have to collaborate with different areas of medicine, including infectious disease. Infectious disease doctors have to closely work with cardiologists, cardiothoracic surgeons. We have to talk to microbiology and also a radiologist and imaging specialist. So this is a classic example how infectious disease doctors collaborate, and it's teamwork with different specialties. So Joe is going to talk about this article today, and he is the first year intern, and I'm welcoming all of everyone and also Joe. So Joe, I would let you talk about a little bit about you and the article.
Great. Hi, everyone. My name is Dr. Joseph LaRosa. I recently graduated from the University of Queensland Ochsner Clinical School. Now I'm in beautiful South Florida, doing my first year of internship at the Broward Health North facility. I'm very enthusiastically starting on infectious disease, and Dr. Gopal asked me to present on an article that we both find very interesting. And now I think I'm going to do that now.
Wonderful.
Uh, so sorry. I'm just bringing up the
Screen. Uh-huh.
PowerPoint, and I'll share my screen now. Okay,
Perfect.
make it full screen. Okay. Oh, sorry. I
Oh.
don't know what happened there.
Mm.
You got it?
No, it was there before. Now it went away.
Share. How about we do it like this? All right, there we go.
Yes.
So the article that I'm presenting on is the state-of-the-art review of complexities in cardiac implantable electronic device infections, a contemporary practical approach. This was in the Clinic of Infectious Disease Journal, Clinical Infectious Disease Journal, and IDSI. So it's Subhavadi et al., and this is the article that I presented on. So an overview of CIED infections and management. So cardiac implantable electronic device infections are complex conditions involving diagnosis, treatment, and decision making with significant morbidity, mortality, and healthcare costs. Uh, CIEDI can be classified into generator pocket site infections and device lead or systemic infective endocarditis, which may occur together or separately. Over two-thirds of CIEDIs occur at the generator pocket site, usually within 3 months to 1 year post-implantation or revision. Common sides include pain, redness, swelling, erythema, induration, purulent drainage, sinus tract, or device exposure. Uh, Differential diagnosis for mild symptoms include post-implant inflammation, hematoma, superficial infection, or hypersensitivity. So diagnostic strategies for suspected CI, EDI. Blood culture should be obtained in all suspected cases. Empiric vancomycin is recommended. Blood culture positivity with gram-positive cocci remains bloodstream infections necessitating device removal. TEE is used to evaluate valvular involvement. Sensitivity is limited for small vegetations. 18F FDG PET CT offers a 78 to 86% sensitivity and 84 to 94% specificity, especially useful for generator pocket or systemic infections. Echo densities on leads are common and not always indicative of infection. Clinical context is critical. Superficial swabs are generally unhelpful. Pocket aspiration is not recommended. The challenges of interpreting imaging results are as follows. Imaging tools like TEE and PET CT are essential, but have pretty significant limitations. Echo densities on leads are often sterile thrombi, so they're difficult to differentiate from infection. PET CT sensitivity varies, higher for pocket infections, lower for lead valve infections. Timing of imaging is critical. Earlier scans yield better results. Cost, availability, and expertise influence the use of PET CT with disparities in access noted. So here's a great diagram about concerning the cardiac implantable electronic device infections in a nutshell. Just going from history and physical through key diagnostic tools and how to they're defined initially. It also gets into where the infection is and treatment principles. In this slide, they broke down history and physical exam of what you would see in CI-EDI. And, with people of younger age, comorbid prior CI-EDI, and other cardiac devices, prior revisions or procedures, complex device with multiple leads, prolonged procedure, postoperative hematoma, they are higher risk. So now we get into the management. So as you can see, this is a little busy, but we go from to how to confirm CI-EDI, and then the with blood cultures, and then we go into the imaging. So for valve vegetation, it's normally if we find a valve vegetation on TEE, the 14 days from the first negative blood cultures is the timing of a new device placement. No valve vegetations, it's 72 hours from the first negative blood culture. But I really like this graph because it shows if there is a sign of pocket generator, a sign of infection, exactly how to treat it with how to diagnose it and initial treatment with empirical oral antistaphylococcal antibiotics. So this one is a little more busy, as you can tell, but it gives a greater understanding of the interaction between the diagnosis with of the bloodstream infections in patients with CIEDI and how they are diagnosed with TEE and subsequently PET CT or and how they're treated. Uh, this would be, they have higher risk for in people with prolonged BSI, community onset, and unknown sources, or the cardiac devices. They have a higher risk for CIED infection. Um, so if there are any questions about this graph, I'll come back to it in the end. So the initial assessment and diagnosis, thorough history and physical exam, which is standard, assess device history, symptoms, and risk factors. The blood cultures obtain at least two sets before starting antibiotics in all suspect cases, and imaging use TEE to assess for lead or valvular involvement. Consider 18 FDG PET-CT for unclear cases or when TEE is inconclusive. So this is what the uh, FDG PET-CT looks like, and these are the advantages, challenges, and future directions. So the advantages are it's non-invasive, it has a high sensitivity and specificity for generator pocket site infection, objectivity of interpretation, other sources of identification, metastatic foci are detected. The challenges are it has reduced sensitivity and specificity for detecting small lead vegetations, costs and limited insurance because it is expensive, varied access to FDG PET-CT, just in terms of, you know, there aren't that many centers that do it, limited nuclear medicine expertise at some medical centers. And then for future directions of specifically CIEDI is, you know, wider use of FDG PET-CT for in terms of a diagnosis. And hopefully there will be strategies that will reduce costs and improve insurance coverage. Digital FDG PET-CT systems with enhanced spatial resolution and motion correction gate would improve in diagnosis. Development of different isotopes for detection of CIEDI and lead infections, and the application, of course, artificial intelligence, which we all talk about always. So in terms of the management here, we go with antibiotic therapy. So empirical therapy is start vancomycin to cover staphylococci, add broad gram-negative coverage if sepsis is suspected. Definitive therapy is tailor antibiotics based on culture results. Duration varies 10 to 14 days for isolated pocket infections, 4 weeks for bloodstream infections or lead vegetations, and 6 weeks for valvular involvement. Oral step-down therapy may be considered after initial IV therapy in select cases. So device management, early and complete extraction is standard for confirmed CIEDI and reduces mortality. Extraction should be performed at centers of excellence with surgical backup and multidisciplinary teams. Specifically, you know, they really need the FDG PET-CT. Device retention considered only when extraction risk outweighs benefits. Long-term suppressive antibiotic therapy may be used, but relapse rates are significant and survival is limited. So timing of reimplantation and interim management, assess ongoing need for the device. If no longer indicated, focus on infection management and wound care. Reimplantation timing for pocket infections without BSI, reimplant after local control. For BSI, wait until blood cultures are negative for at least 72 hours for valvular involvement. Delay reimplantation for more than 14 days after negative cultures. The interim solutions are using a wearable defibrillator, leadless pacemaker, or temporary pacing system as needed. And in this graph, we get into management options with for CIEDI. In cases of ventricular arrhythmia, wearable cardioverter defibrillator, and subcutaneous extra vascular implantable cardioverter defibrillator. Cardiac pacing is also necessary. Temporary pacing system with active fixation leads and externalized pulse generator, leadless pacemaker. So these are the options. And prevention strategies, perioperative measures, minimize hematoma risk, use preoperative antibiotic prophylaxis, specifically cefazolin, and consider antimicrobial impregnated envelopes for high-risk patients. Risk stratification is to identify high-risk patients using validated risk scores to guide preventative interventions. And outpatient, of course, we have to do follow-up and long-term management. So we have to monitor for relapse, regular clinical assessment, and laboratory monitoring, educate patients on signs of infection recurrence. long-term suppression, discuss risk and benefits of chronic suppressive antibiotics if the device is retained. And that's it for me.
Okay, wonderful, wonderful. This is a great presentation, and this is a fantastic article, and I'm glad you presented this. So the main, some of the clinical pearls, as you have mentioned, to never, don't miss a Staph aureus bacteremia on a patient with a pacemaker or ICD. That's very crucial not to miss. And TEE is essential, but as you mentioned, it's not the perfect. Should scan should be the standard of care? That's an unanswered question. And the other question, some knowledge gaps that we have is, if there is an elderly patient coming in frail where device extraction is not possible, chronic suppressive antibiotics, is there any role? Most of the time we may end up doing it. What is the role? So those are some knowledge gap in this area. It's still an evolving topic. And the other thing that is very crucial is if there is a uh, normal pocket examination does not exclude a lead infection. So this is wonderful. Okay, this is a um, I am hoping this is going to be a very useful topic. You're going to see a lot of cases and the timing of reimplantation, the utility of TE, identify the key cases, and that's going to be fun. Okay, thank you everyone for joining.
Thank you.